Welcome back to PScript. I'm Zach Hodges.
And I'm Alice Shanklin.
And today we have part 2 on invasive candidiasis with Dr. Paul Su and Dr. Sara Dong. Dr. Paul Su is an associate professor of pediatrics at Columbia University and Morgan Stanley Children's Hospital. He is an immunocompromised host infectious disease attending. He is a fantastic guest to have discuss today's topic.
Yes. And today we also have Dr. Sara Dong joining us for this conversation. Sara Dong is an adult and pediatric infectious diseases physician at Emory University School of Medicine and Children's Healthcare of Atlanta. Her clinical focus is also transplant and the immunocompromised host. And she is the creator and host of Febrile podcast and learning platform, and the co-host of the ID Puscast podcast, and the program director for the ID Digital Institute. Such fabulous conversation.
Yes. Let's get right to part 2 of this conversation on this high-risk diagnosis, invasive candidiasis in pediatric intensive care.
So I'm finishing up this admission. This is a 9-year-old BALL consolidation chemo. They had pancreatitis. Now they're admitted to the ICU. We're escalating vasoactives, considering intubation, and the patient's first blood culture from 4 days ago is now positive for Candida. So what is invasive candidiasis? How are we defining this?
I think that's a great question. That's a very important question because we see Candida, like I said, colonizing our GI tract, and it's often sent from a urine, right, with a catheter. And so really important to define invasive candidiasis. And so the EORTC, which is kind of the European primary organization for research for patients with cancer, they have something called the Mycosis Study Group, or the MSG. And this group has really defined the cutting edge definitions and criteria for fungal infection. And this is what every ID doc goes to when they wanted to try to characterize what type of fungal infection that they're dealing with. Are they dealing with a proven fungal infection where we're 100% sure, or a probable infection or a possible infection? And so the Mycosis Study Group from the EORTC defines, invasive candidiasis as either candidemia or evidence of invasive organ disease. How do you come across that? How do you define that? And so, or how do you identify that? So when it comes to candidemia, we've already talked about it quite a bit. Your blood cultures are going to be quite good. However, like I said, there's that 50% of patients with invasive candidiasis, with end organ disease, who will not have positive blood cultures. And so in these patients, by definition, the diagnosis would be isolation of Candida from a sterile site. And so if you have an abscess and you're draining it and you get Candida growing from your liver, then that's likely invasive candidiasis. What it doesn't include is isolation of Candida from any site or non-sterile sites. And I think the most common that we see are candidal yeast growing from endotracheal tube that's been there for a while, and the patient had a fever and they are growing yeast. Or we'll see it from a urine in a patient that's had a Foley catheter in for, about a week or so. I think the important thing to remember is those may be suggestive of colonization, but they don't meet the definition for invasive candidiasis, and so the approach is slightly different.
And I would imagine the clinical implications of invasive candidiasis is very different from Candida colonization on the end of an endotracheal tube or a Foley catheter. Can you speak to that some?
Yeah, absolutely. So we know that mortality is a significant risk with invasive candidiasis. Estimates of mortality range from 15% up to 40%, especially in the immunocompromised host. And so when Candida is deep-seated or when it's in the bloodstream, it wreaks havoc because the patients that are prone to these infections are already weak. On the other hand, we know that colonization is common, that all of us are colonized. The implications of treating colonization really have impacts on the patient's toxicity risk and outcomes. If you decide to start an azole, if you decide to start, amphotericin, or even if you start micafungin in a patient that's colonized, you increase the risk of not only drug toxicity, but emergence of drug-resistant Candida, which we're starting to see more and more of. These are two very distinct things. I think that the point that colonization, we know, is a risk factor for infection is something that, as ID physicians, that we never trivialize. We identify that if a patient checks off all those boxes for risk of candidal infection, colonization is definitely one of those check boxes. And so if a patient meets this scenario of high risk, low threshold for suspicion, and has a nodule, we know is colonized with Candida, and we don't have any tests yet, the risk of Candida we know in this patient is high, or is higher.
Yes.
I should say.
Before we dive into treatment, I'd love to ask, so now in this patient, presumably they've got a central line, they're growing Candida from a sterile source after 4 days. We don't know which type yet. Can you two speak to the expected cadence? You expect these blood cultures to be positive? Is 4 days surprising to you? Would 6 hours be surprising to you? When are they growing?
I mean, for Candida or, yeast in a blood culture, they often will not grow as quickly as routine bacteria. So for example, usually when I talk to a patient's family, I'll say, we watch these blood cultures for 5 days. But usually if a bacteria is going to grow, it'll typically grow in the first 48 to 72 hours. But for yeast, I say it can often take that sort of full length of time and may not show up until 4 to 5 days. I'd say the main reason that's also valuable is when you are trying to decide if that patient has, quote, cleared their cultures, because then you often can't use that sort of 48 hours, blood cultures negative, slap in a new line. And I think people are, in general, more conservative about waiting sort of the full length of the blood cultures if you're dealing with Candida, just because of that, because it can take a while for it to show up in the blood culture.
That's helpful.
And I think every ID physician probably has a story. It was day 5. The kid looked really well, and we thought we could do it. And then on day 6, the culture turned positive. And then the repeat culture was positive. So...
yeah,
it's very compelling. Yeah.
That's pretty good. Thinking about our case, you have this patient with many risk factors for invasive fungal infections, now has a positive blood culture for Candida. What is your general mental model for choosing treatment strategy for a patient like this?
So the nice thing is that there are guidelines, right? So in 2016, the IDSA did update their Candida treatment guidelines, which really lay out a very thoughtful approach to the treatment of candidiasis in a quite diverse group of patients. If you have an isolated candidemia, the most common candidal species that you'll see is albicans. And I think traditionally, albicans was thought to compose most of our candidemic infections. However, what we've seen over the last decade or so is really a shift, right, away from albicans. And albicans now makes up, less than 50% of our candidal infections. And so we'll have really an increase in the rise of other subspecies such as parapsilosis or cruzii or glabrata. We've had a rise in these other candidal subspecies. Mycofungin or echinocandins have activity against the vast majority of these. And we know that when we compare the clinical efficacy of mycofungin to ambisome, say in known Candida species, and we compare the toxicity profile compared to amphotericin or ambisome, that mycofungin is superior. There are caveats. For example, if you're concerned for a CNS infection, if you're concerned about a fungal ball or a mycetoma in the kidney, mycofungin will likely not penetrate well into those areas. But the first line recommendation from those 2016 guidelines is really an echinocandin to start while you're waiting for additional data.
And then maybe if there is worsening critical illness, signs of shock, would that lead you towards perhaps the addition or substitution with amphotericin B, or maybe not?
Yeah, so I think that again, the concern here is, are echinocandins perfect, right? And echinocandins are not perfect. And if the patient is progressing or clinically getting worse, I think 2 things. Number 1, do we need to escalate? And number 2, what is the source? What are we dealing with? And what other things do we maybe need to do? If the patient's candidemic, do they have a line? Do they have a vegetation? Do they have an HD cath or something where the problem is not the drug, but the problem is the source of infection that we've not adequately addressed? We are seeing some cases where the MIC, what we call the MIC to echinocandins, may be elevated in some other subspecies of Candida, like glabrata or parapsilosis. And in these cases, if we feel like there may be some risk of resistance, we may choose to go to ambisome. But again, that discussion is very heavily influenced by if the patient is very sick, will they tolerate the ambisome?
So thinking about how these candidal species maybe don't grow as fast as our bacteria pathogens that cause bacteremia, how many days should we give a certain treatment for we say, this is persistent candidemia or this is not effective therapy? And how would you change therapy?
Yeah, so I would say in those settings, again, I'm going to go back to my simple breakdown framework. I think you need to look at host and then you need to look at pathogen, right? And so I think very simply, if you can't tell, it's always, for me, it always comes back to that, to the host and to the pathogen. And so if you have persistent candidemia, again, sure, the question is the drug not effective? That's very possible, but oftentimes the issue is not the drug, right? If you're on any kind of candid or you're on ambisome, more often than not, the issue will have to do with the patient. In this patient, for example, with neutropenia, we know that neutropenia is a risk factor for candidemia and invasive candidiasis. And we know that neutrophils, although we think about neutrophils and mold most frequently, neutrophils are essential in helping the body to fight off candidal infections as well. Patients that have prolonged neutropenia that are candidemic may remain neutropenic for weeks, because they can't clear. And so the question comes up as to how can we best help this patient? It's usually not the drug. Is there anything we can do to help the patient fight it off themselves? So are there neutrophils coming back? Can we give them something that will increase the rate of neutrophil production after chemotherapy? And even in some cases, the question of can we give them neutrophils to help them clear will be raised. And I think these are topics in and of themselves, but I think really important if you have persistent candidemia to go back and look at your patient. So neutropenia, I think, is one. The other is source, right? And so, we know that invasive candidiasis persists beyond candidemia. So if they're persistently candidemic, the chance that they have a source that you have not found is very real. This is when we start looking for hepatosplenic abscesses, or we look for other potential areas of infection. We may ask ophthalmology to come if they're complaining about eye problems. I think in those cases, really important to find out what the source is.
This is when we start moving from gently nudging to remove the line to saying we strongly advocate for removing the catheter.
Because the mortality is pretty high, right? So ID would always appreciate source control, but in these patients, it's actually your job to get that poured out before the sun sets, right? You actually need to get the ball rolling. You can't be yes, I agree, source control, good idea. You need to be
If I'm not mistaken, there are some subtlety to this conversation, right? Depending on the host. Do you have any guiding principles on when you would more firmly recommend getting indwelling lines out and maybe when there might be a little bit more gray area?
This is actually addressed in the 2016 guidelines very wisely. So we know that with this patient who had pancreatitis, there's a possibility that the candidemia was from their gut, and did not colonize that line. That is a possibility. Whereas we know that in non-neutropenic patients, more often than not, when there is a line, that is often the source when we have candida in the blood. That said, I will say, in this patient, the finding of persistent candidemia is extremely worrisome. Persistent candidemia in the setting of a central line, to me, simply means more time for the candida to settle on that line. And once the candida settles on that line, it's not that far from the tricuspid. And once it gets there, we're in big trouble. And we know that this patient has no neutrophils, right? And so there are subtle differences. I think the question is always, when is a CLABSI, and when is it bacteremia or candidemia, and there just happens to be a central line. And I think that is a very real consideration that needs to be made. But I will say 9 out of 10 times in this setting where a patient is neutropenic and they've had a positive culture for candida, and especially if they have a second positive culture for candida, I'm saying we need to take out that line. We know that in kids in the ICU who have candidemia and have their lines retained, they're more than twice as likely to die. Right? And this is not even just neutropenic patients, right? These are all comers. And so we can try in desperate situations. There's been a little bit of experience with antifungal, ambisome locks, and we try to do creative things when we have absolutely no choice. And as ID docs, we defer to our intensivist colleagues to tell us, what our choices are. But we know that removal of that line is going to improve the chances of survival.
Yes. As we move towards maybe the end of our today's conversation on management of these patients with invasive candidiasis, we'd like to know a bit more about when you might recommend some adjunctive treatments that you've already alluded to.
Yeah, so I'll kind of let you know my take on it, and would be very interested to hear what Sara has to say as well. But again, I'm going to come back to, I need to look at my host. I need to look at my kid, right? I need to look at my patient. And I know that this is an infection that can take him away or her away. And this is something that has severe consequences, what we do. So in scenarios where patients are neutropenic, we know that the use of G-CSF is associated with a shorter number of days of neutropenia. And we know that neutropenia is a risk factor for invasive candidiasis and candidemia. And so by corollary, the use of G-CSF to decrease days of neutropenia, you would think, theoretically will decrease the duration of time where the host has no activity or no defenses against Candida. So G-CSF is something that we use commonly in these patients and something that, as long as the oncologists are on board with it, we encourage. The use of granulocytes, I think, is a little bit more controversial because these are very tough scenarios and it's very hard to find uniformity in these cases. And so we know that neutrophils are important in the clearance of these infections. We know that we can donate or infuse granulocytes, which are not native. We know that these granulocytes that we infuse can cause inflammation. And then there are, reports that granulocytes can actually help clear infection. The guidelines around use of granulocytes comes from the Blood Bank Society, and it's very tepid. The guidelines suggest that use of granulocytes may be considered in a patient who is not responding to appropriate antimicrobials if there is anticipated count recovery. And so the idea is that with granulocytes, can we hold off an infection until the neutrophils regenerate and the patient can defend themselves? There was one study that took a stab to do the right study to look at this in the right way. It was called the Ring Trial, and this was done in the late 2010s. And this is a multi-center study that looked at patients with neutropenia and febrile neutropenia and documented infections and looked at treatment with antimicrobials and treatment with antimicrobials and granulocytes. And that study looked at microbial response and then also looked at mortality. The study was supposed to enroll somewhere along the lines of 200 to 300 patients. And in the end, had to be closed down after about 50% of that. And so the study in the end did not find any significant difference in mortality or outcomes between neutropenic patients who got granulocytes and who did not. That said, when you look at that study, they did a secondary analysis and the dosing of the granulocytes was not standardized, for example. The type of infection was not standardized. About 50% of these infections were fungal, but we also had bacterial infections, like pneumonia and other things, and bacteremia. And so if we're looking specifically at the role of granulocytes in fungal infections in neutropenic patients, there really is no targeted data. But when they looked at their outcomes in the study, which showed essentially equal microbial response between the two arms, they broke it up and started looking at patients who had received what we call low-dose granulocytes versus high-dose. And that was very intriguing because it was obviously not powered to look at that. But what they found was a trend. And they found that patients that received nothing were at a certain risk of mortality. That patients who received low-dose granulocytes actually had a higher rate of mortality, or their survival was lower than those patients that received nothing. But patients that received high-dose granulocytes actually had significantly about 20% higher survival. And so this raises a lot of questions, and it kind of brings us where we are today, where nobody really knows the answer. I will say that many of us have probably had a traumatic experience as an ID physician taking care of a very sick patient who is maybe fighting Aspergillus pneumonia, maybe had relapsed AML and is not going to have count recovery and is just getting worse. And the family wants to try something and we get granulocytes. And the granulocytes tip them over and then they go into florid respiratory failure and they don't make it. I think that is something that many of us have experienced. And I think it's not unexpected. We know that granulocytes cause significant inflammation. And in the wrong patient, it can often be the deciding factor that will tip them over and kill them. So that said, I think that there's a lot of room here for exploration, or there's a lot of room for investigation, whether or not granulocytes, maybe in an earlier phase or before someone gets to that point, is it associated with clearance? The challenge in Transplant ID is that our cohorts are not large. Finding access to enough patients to power that study is going to be difficult. And so, we do the best that we can with the data that we have.
Oh, absolutely. And definitely difficult decisions being made in those cases.
Yeah, I've had the exact experience that Paul just described. But yeah, I think it's ultimately ends up being a case-by-case conversation with the hem-onc team, ID, and the critical care team and the patient's family. And, hopefully in the future, we'll have a better understanding of how to use these tools. But I agree. I think it's challenging and that we don't quite know how to best provide it to our patients.
Yes. Well, I really appreciate y'all's thoughts today. This is a consult that I've been wanting to call for a while. This is
a delight calling ID.
This is a conversation that, gosh, I feel like I could benefit from every time I'm taking care of a patient with a similar condition in our ICU. And we definitely could not do it without people like you in infectious disease, taking those world-class histories, doing that physical exam, reminding us of things that we're not thinking about. And I really appreciate your time today and sharing this knowledge with our listeners. I wanted to give you one more open-ended question. It would be happy for you guys to maybe, if you want to reinforce a key point or if you would like to plug anything for our listeners, the floor is yours.
Yeah, thanks so much, guys, for the chance to be on here with you. It's a pleasure. So I'm going to go back to what I started with, which is a common theme. So these are always tough cases. These kids are always sick. They always have the odds stacked against them. They're often trying to get through for their second chance at life, right? Either they've had a primary cancer diagnosis or a transplant. These are often kids that are excluded from the rule books. The studies that are done looking at duration of therapy often will exclude these kids. The studies that are done looking at efficacy of intervention A, B, or C often will not include these kids. So the perspective I take as a transplant ID doc, again, is to go and really know my host. Know what is going on. What is their functional immunity? There's a phrase we used in transplant ID called net state of immunosuppression. And that can mean a lot of different things. But to me, it boils down to what is their functional immunity and what is their functional immune defect? And what is that predisposing them to? And taking that into account, that really gives you a lens to think about, what am I worried about? What are the pathogens that will take advantage of this kid's weakness? And what else is going on in this kid that is going to give an advantage to this organism or this fungus, whether it be a central line, whether it be an abscess or another source. But I think breaking it down into who is your host, who is your patient, who is the kid that you're treating is so important in defining what you want to do, because these patients are not cookie cutter and they will not fit into many of the algorithms that we use for everyone else. And so,
yeah, and maybe I'll build off of that by just leaving with a framework that I think is helpful for why does my patient still have fever when they're in the ICU? Why do they seem like they're getting worse despite what I think is appropriate antimicrobial therapy? And we've kind of talked about all of these along the way, but really 5 big things. Number one, well, it really should be number 1 through 10 is source control. And that's always the key consideration if someone seems to be worse or progressing or febrile on treatment. And you may need to think about is there a new complication now from that patient's infection that explains why they are worse? And then the rest are all wrong questions, wrong bug, wrong host, wrong diagnosis, wrong drug. And so I'll just go through them. So for wrong bug, it's pretty clear. Do you have the right organism identified? And if you do have that organism and something seems off, is there any chance there's a co-infection? So that's sort of the wrong bug. The wrong host we've talked, multiple times about, but basically, are you not having an expected response to therapy because there is a misunderstanding about the host immune response, or there's something about their immune response that you can't really fix? And that's kind of what we've talked about with neutropenia. And then I think in the ICU, that question of wrong diagnosis, is there something else that's causing fever, or is there a drug reaction, drug fever? Is there a different explanation for what's happening that happens to be at the same sort of time as the infection? And I think for wrong drug, we always talk about, do you have the right drug at the right dose? And, is the patient taking the medicine? Are they absorbing it? Does your drug penetrate into the place that you are trying to treat? And honestly, that's mostly just going to be an issue for those more protected spaces, brain and eye and maybe prostate in older patients, or their drug interactions? Is there drug resistance? But I think if you have that framework to like look at your patient and walk through the different examples, usually you're going to find it. But I think that's a useful couple of questions that you can apply to really any patient who's already on therapy and you're like, I just don't understand why they're not getting better. And hopefully that'll help someone in the future.
Oh, absolutely. Well, Sara Dong and Paul Su, thank you both so much for joining us today. Big fans of ID, big fans of the Febrile podcast, and we appreciate it.
Thank you.
Thank you, guys.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.